Good afternoon, everyone. My name is Natalie Foster, and I'm a senior analyst in the Maternal and Child Health team at the Association of State and Territorial Health Officials, or ASTHO. And I'm excited to welcome you all to our first ASTHOConnect of Year Two for the Opioid Use Disorder, Maternal Outcomes, and Neonatal Abstinence Syndrome Initiative, or OMNI, learning community. We are thrilled to have you on today's webinar and want to give a special welcome to members of the New York team who were unable to join us at the in-person meeting in August. As Vic mentioned, please take a moment to type your state team name into the chat box so we know who is on the call today. I'd also like to take a second to thank our partners at CDC's Division of Reproductive Health and National Center for Birth Defects and Developmental Disabilities, as well as HRSA's Bureau of Primary Health Care for their continued support on this project. Today's webinar is on integrating maternal care and substance use treatment. Many state teams are prioritizing access to quality health care as a goal for your state. And today we're going to hear from speakers from two different programs who have dedicated their work to ensuring that pregnant patients with opioid use disorder are able to receive quality medical care for their pregnancy and addiction, as well as behavioral support and the other social services. After we hear from Drs. Elisabeth Johnson and Lorraine Milio about their programs, ASTHO and CDC will provide an overview of next steps and highlight some resources to look forward to from the learning community. The objectives for today's webinar are to highlight two models integrating maternal health care and substance use treatment services, describe key program components and stakeholders, and start to identify opportunities for replication, and discuss policy elements necessary to support integration of maternal health care and substance use treatment services at the state level. I'm thrilled to introduce our first speaker, Dr. Elisabeth Johnson. Dr. Johnson is the Director of Health Services at UNC Horizons. Her full bio is in the bio document that was included in the calendar hold. Please type your questions for Dr. Johnson into the question and answers box at the bottom of the bar, and we'll answer all questions at the end of both presentations. Dr. Johnson, take it away.
Great, thank you so much, Natalie. Next slide. So just briefly, my goals for today are just to review really briefly the scope of the problem. I think most of us are pretty well grounded in the issue of women with substance use disorders, and then just to describe the model that we use here at Horizons. Next slide. So I have no financial disclosures, just real briefly disclosures about the medications that I'm going to be talking about. Next slide. So this is a graph I think most people have seen multiple times, just looking at the scope of the problem within the United States. This is data from looking at overdose deaths between 2000 and 2016, with, of course, one of the more notable things to be looking at as we get towards 2016, particularly the blue line representing synthetic opioids other than methadone, so primarily fentanyl being implicated in the majority of overdose deaths. And the uptick in heroin and some of the other opioids. Next slide. And then I just included this slide. The program that I work for is in North Carolina, just to show that North Carolina is reflective of the national trends that have been seen, with a huge uptick in 2016, 2017, with synthetic opioid being the primary cause of overdose deaths in our state as well. Next slide. So when we think specifically about pregnancy data that came from SAMHSA, looking at data from 2011 to 2012, showed that the two most common drugs used by non-pregnant women have been alcohol and tobacco, and that this is true for pregnant women as well. Among pregnant women in the United States, about 16% use tobacco, 9.4% drank alcohol during this time, and about 5% used illicit drugs. And when we start thinking about screening for substance use disorders, it is really unusual for women to initiate a new substance use disorder during pregnancy, to be diagnosed with that, but it is important for us to be asking all women about substance use before they get pregnant, what substance use is in their family, if their partners are using, and their peers. Next slide. So some of the things that we particularly worry about when we think about opioid exposure during pregnancy We do know that the use of illicit opioids during pregnancy is associated with an increased risk for adverse outcomes for both mom and baby, and that the American College of Obstetrics and Gynecology has put forth in 2012 that the standard of care was to refer women for opioid-assisted therapy, and put out there officially that supervised tapered doses of opioids during pregnancy often results in relapse to former use, and that this is really not recommended. There still has been some discussion in the OB and substance use literature about using detox during pregnancy, but in general, the assertion is that tapering mom off of her opioids during pregnancy is fairly risky. We do know that the abrupt discontinuation of opioids in a woman who is opioid dependent while she's pregnant can have some adverse outcomes for the baby, including preterm labor, fetal distress, or fetal demise. Next slide. So, as the standard of care is using medication-assisted treatment for women with opioid use disorder during pregnancy, we do know that it has multiple advantages. So the primary advantage is that it prevents the erratic maternal opioid levels that will occur with illicit opioid use. So it lessens fetal exposure to repeated withdrawal. It reduces cravings for mom, and therefore we hope that it will also then decrease the other illicit drugs that babies might be exposed to. If you can get abstinence or a real harm reduction approach, that's the way I generally look at things, even if it's not complete abstinence, but mom is decreasing her use, that really allows us an opportunity to work with mom on other behavioral changes that will help decrease her overall health risk for both her and her baby. And we also know that if we get mom stable, it greatly reduces the likelihood of pregnancy complications. Next slide. So what are some of the options for medication-assisted treatment? Methadone has probably the most experience. It's been around for quite a long time. I'm sure everyone here is familiar. It's daily dosing as the model. Buprenorphine. Here at Horizons, we've used the combo product, primarily Suboxone, for many, many years, even before it was sort of the standard that people were going to. There's still a lot in the community of people thinking that they need to use the mono product or Subutex, but that's not really borne out to be true. So that is, the combo product is available for moms as an option. The one option that is not really out there, not a lot known about it, is naltrexone during pregnancy. We are hoping to do have some research findings that will demonstrate its efficacy. There are some early studies that have come out in Australia that show no severe adverse consequences for the baby if mom is on naltrexone during pregnancy. Next slide. I'd never do a talk about opioid use disorder and pregnancy without mentioning trauma. Next slide. So we know that trauma exposure is a huge risk factor for women with substance use disorders. These can include sexual and physical assaults, childhood sexual and physical abuse, domestic violence. All of these things have been found to predict both the initiation of drug use by women and the development of drug use disorders in women. And there was an early study in 1997 that reported a lifetime history of trauma in between 55 and 99% of women who have used substances compared with population rates. Next slide. So we know that women who have a substance use disorder are more likely to report being sexually abused and more emotional abuse by their perpetrators more frequently and for longer periods of time. And there have been more recent studies that have estimate that about 80% of women seeking treatment for substance use disorders report some history of trauma. Next slide. So to make it, sort of bring it to a real life example, so here at UNC Horizons, we do a screening when women first come into our program. So this data that we collect is really for the first time that women are really having a chance to sit down with us, so they don't really know us that well. So I'd like to keep that in mind when we're thinking about what they're actually reporting to us. So this is data that we do it from the academic year, so July to July. So this is data from our most recent academic year. So thinking about the different types of trauma that the women that we take care of have experienced in their lifetime. So 53% reported being homeless at least one time, 77% reported emotional abuse, 50% physical abuse, 67% reported sexual abuse or assault. The average age of first assault was 9 years of age. 71% reported experiencing domestic violence, and 15% reported forced sex work or trafficking. So overall, 86% of our new clients reported at least one form of interpersonal violence. This number has been consistent. I've been at Horizons for 6 years, and it's always been in the low to mid 80s. And most of us will believe that that number gets much closer to 100% as women get more comfortable and are willing to disclose their histories to us. So as they get further along in their treatment, this 86% actually goes up. Next slide. So why do we worry about trauma? Next slide. Just real briefly, PTSD and pregnancy. We know that PTSD has been associated with shorter gestation, lower birth weight, negative effects on maternal self-care, and then infant emotional and cognitive development, difficulty with maternal attachment. And we know that pregnant women with PTSD have higher rates of suicidal thoughts and psychiatric comorbidities than non-pregnant women with PTSD. Next slide. So what's the solution? Integrated care is what I believe to be the solution to a lot of issues, but particularly to substance use during pregnancy. It is where we have primary care, mental health, and substance use treatment all working together and under the same roof. Next slide. So we know that integrated care works. It can save up to $213,000 per month. It really works, it improves lives, and it can reduce overall healthcare costs. Next slide. So before I talk about our model as an example of integrated care, just again, in addition to the trauma, just who we are taking care of. So this is, again, data from our most recent academic year. Our average age, these are women coming into residential treatment with us. Average age is 30 years of age. And there's our race and ethnicity breakdown. It's fairly representative of the population that is in this immediate area. 22% have less than a high school education. Primarily, 70% women, their primary diagnosis is opioid use disorder, which included heroin, 13% cocaine, 9% alcohol, and the majority of our women reported an average of 10 years of regular substance use. Most of our women have some kind of mental health disorder, so co-occurring disorders, and 28% reported more than one or more suicide attempts. And the majority of our women use nicotine. Next slide. So to talk about our model for prenatal care, this is actually how the entire Horizons program, which is much bigger in scope now, but it started out of a prenatal clinic at UNC and OBGYN. Next slide. So the structure of our clinic, the clinic is dedicated to the care of pregnant women with substance use disorders. So I do not see pregnant women without substance use disorder on the same day. We have a team approach. It's myself, we have a therapist. We also have a peer support specialist who is in clinic with me. So it's really an all-encompassing clinic visit. A peer support specialist provides support, assistance, and access to community resources and services. Prior to our peer support specialist, we had a case manager in this position. The therapist provides support and counseling. I manage their medication-assisted treatment and provide their prenatal care. Our clinical visits are more frequent than many prenatal care schedules, so it's rare that I go longer than 2 weeks without seeing a patient. And one of the things that we have found is that having a consistent provider who is able to dedicate the necessary time to each client is really key. I don't have 15-minute prenatal care appointments. Women usually are here for a half an hour, if not longer. Not all that time is face-to-face time with me, but when you have 3 different people going into rooms, they can be here for quite some time. Next slide. So just briefly about the environment, we are an outpatient clinic. We have lots of different people from different disciplines in the same setting. And then all of our staff members have been educated about risk factors for substance abuse and understand the need for compassion. This is from front desk to the nurses, I mean, everyone. So the women, we really pride ourselves on being a trauma responsive environment. In this clinic right now, we are fortunate to be embedded in our overall treatment program. Previously, we were in an outpatient clinic for the bigger healthcare system. And when we initially made that, when we were initially in that environment, there were some people worried about whether the women that I take care of would be disruptive to the waiting room, and that did not prove to be true. And we did a lot of training and talking to the front desk staff for how to take care of the women that we take care of. So I really do allow more time for each visit. And I don't have a strict policy for late arrivals. My general approach is if you make it on the right day, I'm going to see you. If you're really, really late to a visit, I'm not going to make other people wait because you were late, but I definitely will work people in. And some people are question that thought and that policy. I will say it is more likely than not that women are on time. People sort of have this preconceived notion that the patients I take care of are going to always be late and they'll take advantage of this policy, but that's actually not true. And the majority of the women that I take care of travel an hour plus to get here. So they may have issues with getting a ride, or their cars are not always the most reliable and they can have difficulties there. And then we have found over time that the frequent visits allow plenty of more opportunities for us all to build rapport with the patients that we take care of. Next slide. So just real briefly, how many people we're taking care of. So last year I took care of a total of 95 women, 57 of whom received the combo product Suboxone, and 10 were on Subutex through our clinic. We had 58 babies who were born in the program, and 43 of those were born at UNC. This is just a breakdown of the number of visits that we did in that academic year. Next slide. This is what we're probably the most proud of, is our birth outcomes. The bottom line is, there's a lot of words on this slide. I apologize for that. But down at the bottom, really consistently, this is data from all the years that I have been here at Horizons, but we have consistently had really good birth outcomes when you look at birth weight and gestational age. Next slide. So this is a much less busy slide that also shows the data, and this has been pretty consistent too. So the red bar is untreated drug-exposed women, so sort of as a control. And then we have the yellow is the state of North Carolina in general, so those are birth outcomes. So it's gestational age and birth weight, and then the blue is Horizons. So we have consistently done better than the state when we have a population that a lot of people would argue are pretty high risk. And next slide. I don't need to go through all of this because I want to be mindful of time, but here are just some current research projects that we have going on where we are looking. One study, the mother dyad, is giving moms a choice between going through withdrawal or starting buprenorphine, and they have the choice. If they choose withdrawal and then change their mind, they have the ability to do that, or vice versa. The one that I'm excited about all of them, but I'm particularly excited about Mom Nest, which is going to allow us to look at the pharmacokinetics and efficacy of naltrexone versus buprenorphine in pregnancy. I think women need to be able to have all options on the table when it comes to opioid treatment. And then the HOPE study is going to be a long-term follow-up study looking at moms and children who've received HERP services and kind of looking at how much treatment they got and looking at different outcomes, housing, employment, substance use, parenting practices, etc. Next slide. And when we think about next steps, if people are wanting to replicate something like what we do here, integration of prenatal care and substance use really requires building relationships with prenatal care providers in the community, hospitals that provide labor and delivery services, local DSS or Child Protective Services, the legal system, substance use treatment programs for women and children, particularly for residential treatment, and then insurance providers. Next slide. And recent efforts that we have made on sort of the policy advocacy front, the most recent thing that I personally was involved in was giving a presentation at a state committee meeting about a proposed bill that was trying to make the process faster in the termination of parental rights for women with substance use disorder. When we think about policy and advocacy, it really requires a network so that you can stay up to date on state and national issues. Having an integrated approach works really well, so multiple specialties. There's lots of different ways you can get the information. And then really to kind of take a step back and remember that many social problems and solutions have interacting factors. So our women are hugely impacted by the ability to find affordable housing, be able to find jobs, education, etc. And it's really, really important when you think about doing policy and advocacy to include the voices of the people that we care for, so the patients themselves as well as family members. Next slide, I think that's it. Oh, and just resources, and then at the end of my slide deck, which I think will be available, right, Natalie, is references and resources. So I don't need to go through all that. Thank you all.
Thank you so much, Dr. Johnson, for that excellent presentation. The slides will be available. They've been put into the calendar hold, so I definitely encourage you to check those out and reach out to Dr. Johnson with any questions. And I will now turn it over to Dr. Lorraine Milio. Dr. Milio is the OBGYN Director at Johns Hopkins Center for Addiction and Pregnancy, and is also an assistant professor in the Department of Gynecology and Obstetrics at Hopkins Medicine. Her bio is also included in the document in the calendar hold. Please continue to type any questions that you have for Dr. Milio or Dr. Johnson into the question and answer box, and we will answer all questions after Dr. Milio's presentation. Dr. Milio, you can take it away.
Thank you. Hopefully our two presentations are complementary. Next slide. So, as you know, pregnancy is just a unique time in which young adults engage with the healthcare system, and for young women, it's often the only time that they engage. And what we have found is that pregnant women usually look beyond their own needs and problems in order to achieve the best outcome for the developing fetus. And for many of them, this is a new level of responsibility. So we focus that all care really needs to consider this mother-infant dyad and encouraging the women to consider themselves together with the developing fetus. Next slide. So we really look at pregnancy as a public health platform, and it's just a time to improve the health of women with chronic disease, including substance use disorder. I have a background in diabetes and pregnancy, and I often think about substance use disorder in some similar fashions, and that my goals are twofold. One is to optimize perinatal outcome, but also for the woman to make the healthcare lifestyle changes that will enable the woman to maintain health in order to raise the child. And we equally emphasize both of these goals to our patients. Next. So most importantly is considering substance use disorder as a chronic relapsing disease. And that's a very difficult concept for people who want to focus on recovery, as if it's sort of a once and you're done type of situation. And then understanding it as a brain disorder with real behavioral manifestations, and understanding that life becomes focused on feeding the cravings and withdrawal symptoms in order to not feel sick. That it's not about getting high, but it's actually on trying to feel normal to get through the day. Next slide. This is simply a MRI scan, just showing just one slide to look at the effects of various drugs on the brain, and this is just looking at the dopamine D2 receptors. And as you can see, with the control being on the left, that all of these drugs, cocaine, methamphetamines, alcohol, heroin, all have a decrease in the dopamine receptors. Next slide. And just as the prior speaker was talking about intimate partner violence, which I'm very supportive of everything she said about that, we also need to always think about stigma and behavior in this population. These are patients who tend to have poor coping skills. They tend to have a fight or flight mentality. They're often easily agitated. Their development is arrested in adolescence, which is when many of them have started their substance abuse, and often have a very short attention span. And then you often have to deal with partners and family members with poor behavior, and this can be disruptive both in the clinic and in the hospital setting. And these patients often have a lot of family emergencies caused by partners and other family members. And then we also then have to deal with what to do about active drug use, both when they're in the clinic and as well as on labor and delivery. Next slide. So most patients with substance use disorder, opioid use disorder, have had negative interactions with hospital staff in the past and have felt stigmatized and are very sensitive to that. So it's really important, and as Elisabeth also mentioned, it's important for the whole staff to be educated and to have a positive attitude, both with body language and with conversation, and to really understand that addiction is a disease, not just bad behavior, to know when to limit interrogation, to be very sensitive where that client patient is at a given time, to have accountability in dealing with vulnerable patients, and really, because I've seen very often that staff, whether it's hospital staff, clinic staff, can actually ramp up escalate a bad situation, and teaching de-escalation techniques is real important. And then knowing that staff have good support and backup, and then the importance of staff education. And all of these things are helpful to reduce the stigma in dealing with these patients. Thank you. Next slide. Go past the cases. I'm not going to talk about the cases. Go through the cases. Okay. So as we discussed before, so 34% of drug abusers in the U.S. are women, and at least 4% of pregnant women or past month users of illicit drugs, and that polysubstance use is the norm, not the exception. And I have sometimes found that patients will be using multiple substances that we were not aware of. I had patients who we knew abused alcohol, and that was her drug of choice until she came into the ED having overdosed on heroin. And up until that point, she had not disclosed to us that heroin was her drug, also a drug that she used. This past weekend, I had a patient who has a severe opioid use disorder who came into labor and delivery having just drank a fifth of alcohol. So one always has to be looking at other substances in addition to whatever the drug of choice is for an individual client. Next, please. And then when we look at the problem, there are real differences between substance abusing women versus men. When it comes to alcohol, women have a more rapid transition from initial alcohol abuse to dependence. They have more interpersonal difficulties. They have a higher rate of clinical depression, post-traumatic stress disorder, and trauma. They tend to live in more violent environment and have an increased rate of being victimized, as was just discussed. And child abuse. They often not only have been victims of child abuse, but they do have an increased risk of being a perpetrator as well. Next. So substance abusing women tend to be more susceptible than men to both medical consequences, liver disease and hepatitis, the detrimental effects of alcohol on the brain, as well as having an early death. Next. And we deal in our clinic with a lot of extensive medical complications that result directly from drug abuse. I see a lot of cellulitis. I've seen it, cellulitis and abscesses, often MRSA-related on all parts of the body. We have an increased rate of bacteremia, endocarditis, and then the risk of HIV/AIDS, most often through heterosexual transmission. Next slide. And as Elisabeth had mentioned, for alcohol-dependent women, the odds ratio is so greatly increased for both affective disorders and anxiety disorders, and a greatly increase in history of suicide attempts. Next slide. And my data is a little lower as far as up to 60% having post-traumatic stress disorder in pregnant women who have substance use disorders, but we certainly childhood physical or sexual abuse is very common. And I find often that these clients are not very forthcoming when they first come to us, as Elisabeth had mentioned, it being there were strangers to them, but over the course of time, often we discover more of their history of abuse. Next slide. Already been mentioned, obstetrical complications resulting directly from drug abuse, the poor fetal growth or premature delivery, increase in urinary infections. We see some increase in hypertension because of the high use of benzodiazepines, and patients will use clonidine as a form of, together with other benzos, and that can have significant rebound hypertension. An increased risk of spontaneous abortion, in utero death, as well as SIDS. Next slide. And, multiple neonatal complications, and of course, all of these are associated with often both opioids, alcohol, cocaine, etc. Next slide. And in addition to all the medical stuff, we are dealing with a lot of lifestyle complications, and including the poor nutrition Cigarette smoking, I agree. Nationwide, in substance abusing pregnant women has been reported to be 80 to 93% of the population, compared to about 14% nationwide for pregnant women who do not have a substance use disorder. Homelessness is a major problem. Unemployment, poor social supports, violent social environments, and a lot of family problems, including loss of custody of older children. Next slide. So you often have fragmented health care, minimal financial resources, depression, and legal problems. And this makes providing both prenatal care and substance use disorder treatment very challenging. Next. And I already talked about the unfriendly healthcare system, poorly integrated treatment services, lack of transportation, a major issue, and limited child care resources. Substance use disorder programs in general are not gender sensitive and really not sensitive to the fact that many young women with substance use disorder do have child care responsibilities. Next slide. So care of the substance abusing pregnant woman is really a multidisciplinary effort in order to optimize perinatal care. And my list is not very different than Elisabeth's list. You need prenatal care, you need evaluation and treatment for comorbidities, both psychiatric and medical. And I will say that when people have medical comorbidities, such as seizure disorders, diabetes, hypertension, heart disease, they tend to come to us poorly controlled and with very little follow-up prior to initiating treatment. Substance abuse treatment, nutritional counseling. Many of our patients either gain excessive weight or don't gain weight. They often have nausea and vomiting throughout their pregnancy. And then lastly, social service involvement. Next. So based on this, CAP was developed in 1991 as a one-stop shopping program, and the goal was to integrate substance abuse treatment, mental health and psychiatric consultation, obstetrical evaluation and care. Initially, for the first 15 years, we had child care and a developmental play program. We have pediatric health care and a residential service. Next slide. So it was started in 1991 as a partnership between Johns Hopkins Medical Center and Maryland Department of Health and Mental Hygiene, when after a pilot program in which an obstetrician was embedded in a methadone program, and we were able to show that perinatal outcomes improved just by having the presence of prenatal care. This was a collaboration among the departments of obstetrics and gynecology, pediatrics, and psychiatry. It was initially under the OB/GYN department, then under hospital administration, and now it's been under the Department of Psychiatry. Next slide. In order to be eligible for the Center for Addiction and Pregnancy, all you need is a positive pregnancy test or current or recent history of substance abuse. And we take women with alcohol, prescription drugs, illegal drugs, heroin, cocaine, PCP, etc. There's not much methamphetamine in Maryland yet, but we are beginning to see some patients with that as well. There needs to be a willingness for treatment. However, because we're a unique program in the state of Maryland, we actually take women at varying levels of readiness for treatment. And then lastly, the women have to agree to abide by the rules and regulations of the program. Next. So the capacity of CAP, we have housing services for 16 women from 4:30 p.m. to 8:30 in the morning. And we have an intensive outpatient program, which is regulated by the state of Maryland as 15 patients per mental health counselors. Our capacity has ranged largely over the years, anywhere from 45 to 105 patients at any one time. Next slide. So we serve on a daily basis all of Baltimore City and the surrounding counties, where within commuting distance by either car or public transportation. And this has changed over the years. When the program first started in the 1990s, we were primarily dealing with inner city African American heroin as the primary drug of choice. And now our racial distribution is almost 50-50, African American and white. We have very few Latino or Asian participants, and we get probably an equal number of people coming from the surrounding communities as from inside Baltimore City. We also see clients from the entire state of Maryland who will see for stabilization, for detoxification, and for initiation of medication-assisted therapy. These patients will often stay with us on the housing unit, the CAP housing unit is the CHU, or have nearby housing arrangements. Next slide. So we have intensive outpatient programming, and we have 3 steps in this program. Step 1, which is what the majority of patients come to us, enroll in, and are eligible for, is 2 hours a day of programming for 5 days a week, or if you're on the housing unit, 2 hours a day for 7 days per week. And this includes a half hour to an hour of time one-on-one with your individual mental health counselor. And then step 2 is 3 hours a day for 3 days per week. And then step 1, which is our least intensive, is 1 hour on 1 day per week. Billing for intensive outpatient programming requires 9 hours per week in a calendar week, and we give various incentives, gift cards, transportation, reimbursement, in order to incentivize patients to complete the programming each week. Patients may enroll at any time during the pregnancy, but insurance will not allow us to enroll after delivery. Originally, in the early 1990s, patients were allowed to stay in the program about a year postpartum. With the introduction of MCOs in 97, this was decreased to 6 to 8 weeks postpartum. But now, with the focus being on postpartum maternal deaths from substance use disorder, we find the MCOs have liberalized considerably on a case-by-case basis, and we're able to keep women for several months after delivery. Next slide. Next slide. Some of the topics that we cover in our intensive outpatient program include the importance of prenatal care, pregnancy topics. These women tend to not have very much knowledge at all about their own bodies, what the changes are during pregnancy. We talk about consequences of drug use during pregnancy. We focus on improving self-esteem. We find that if the women don't have hope, they're not going to be successful in recovery. We talk about coping with depression, spend a lot of time talking about relapse prevention, discuss contraception. parenting skills training, and life skills training. We have a pediatrician from Columbia who runs our parenting program as well as our trauma program. And so we actually have, it's a nationwide syllabus called Seeking Safety for women who have a history with of intimate partner violence. Next slide. We offer MAT, medication-assisted therapy, methadone maintenance, buprenorphine maintenance. Right now, we're primarily using Subutex, buprenorphine alone. However, we have a research project going right now looking at fetal effects of Suboxone, or the buprenorphine plus naloxone maintenance. We do offer detoxifications from opioid, alcohol, and benzodiazepine in cooperation with our chemical dependency unit, which is in the hospital. And we also take have patients who simply need to stabilize. Just one comment about opioid detoxification. Elisabeth went over very well what some of the official recommendations are. We find that there are some women who absolutely refuse maintenance treatment, either because of pressure from their family or their own personal feeling about it just being a substitution. And so we will allow these women to go through opioid detoxification. However, about half of them will switch over to maintenance at some point. And so we find that admitting them for medication assisted supervised detoxification at least gets them into our program. At least gets them into the program and allows them to be more active in their decision making. We also have situations where patients live more than an hour away from either a buprenorphine provider or a methadone clinic, and that's another issue. Next slide. So we partner with the inpatient chemical dependency unit to provide detoxification for the pregnant women, and this is a 6-night, 5-day stay. And we follow this up by stabilization on the CAP housing unit for several days to several weeks. So the goal was to have the prenatal postpartum clinic embedded in CAP while maintaining continuity with labor and delivery. Next slide. And so we are on site 3.5 days per week providing obstetrical services, but we have an obstetrical nurse there 5 days a week, and we also have a nurse present 7 days a week to take care of the housing unit patients. We have a mid-level provider as well as a perinatologist. And then the CAP patients are delivered at Johns Hopkins Bayview, and I often will coordinate the overall medical care for these patients as needed. Next slide. We also see people at more frequent intervals, and we see them through postpartum or post-abortion visit until all their OB problems are resolved. Next slide. We have an emphasis on sexually transmitted diseases. We provide HIV treatment for the HIV-infected women at CAP, and then we do referrals outside for other services. Next slide. All the patients are offered a psychiatric evaluation and ongoing management, including psychiatric meds. The methadone and buprenorphine is actually supervised by a psychiatrist that is based at CAP. Next slide. And we provide complete pediatric care for infants from CAP pregnancies, older and younger siblings up to age 21. Unfortunately, it's limited to just one MCO, which is about 40% of our clients. and then we refer mothers to ongoing substance use disorder care as needed. Next slide. And either postpartum or antepartum, we will refer patients to long-term residential programs that specialize in mother-infant care, other IOP programs, or MAT-only programs as needed. Next. So our solutions really is early and consistent prenatal care, participation in drug rehabilitation, access to psychiatric services, and stabilization of living situations, working hand in hand in order to optimize perinatal outcome. I think that's it.
Great. Thank you so much, Drs. Johnson and Milio, for your excellent presentation. We have a couple minutes for one or two questions. So we had a few questions come in through the Q&A box at the bottom of the screen. The first question is for Elisabeth. Who did the Australian study for efficacy of naltrexone being saved pregnancy, or who are the authors of that study?
I can send the references, but those studies looked at women who were on naltrexone prior to getting pregnant, and then it followed them. They were continued during pregnancy, and they looked at birth outcomes. So it was not a study where women were started on it while they were pregnant. So we're hoping that our site, as well as some other sites across the country, and internationally as well, can start showing efficacy so it can be offered to pregnant women as an option so that they have access to the full spectrum of medications for treatment of opioid use disorder.
Perfect. Thank you, Dr. Johnson. And our next question is for Dr. Milio. What is your threshold or parameters for releasing a patient from outpatient medication-assisted treatment during her pregnancy?
Oh, can you repeat that? I'm sorry.
Sure. So the question is, what is your threshold or parameters for releasing a patient from outpatient medication-assisted treatment during her pregnancy?
Usually, well, there are two reasons why patients may get released. One is they themselves, often it's a transportation or housing situation where they have either are moving away or they just are living too far away to make daily participation possible. And then others, if they are administratively discharged because of behavioral issues, then that basically means that they have threatened staff or other patients, have had physical altercations, fairly significant behavioral issues that really destabilize the program.
Great. Thank you so much, Dr. Milio. And in the interest of time, we had another question come in, but I'll field it with the presenters after our webinar today, and we'll send out the answer to all participants in our thank you email. So again, thank you so much to Dr. Johnson and Dr. Milio for your excellent presentations. With that, I'll turn it over to Charlene Prolinger, Chief of Maternal and Infant Health Branch in the Division of Reproductive Health in the National Center for Chronic Disease Prevention and Health Promotion at the CDC, who will share some programs available to states from CDC related to pregnant and postpartum women with opioid disorder. With that, I'll turn it over to you, Charlene.
Thank you so much, Sana. I just wanted to spend a couple of minutes talking about some of the work that we're doing in the Division of Reproductive Health to support what you all are implementing in your states. As you can see, this is a map of the U.S., and it really describes a multi-pronged approach that the Division of Reproductive Health is leading in several activities to prevent OUD among pregnant and postpartum women and to make sure women with OUD get proper treatment. This map shows the states participating in this wide array of activities. I'll start with the OMNI Learning Community. This is one of those efforts, and the map shows both year one and now year two participating states in the diamond shape. But I also wanted to talk about the Pregnancy Risk Assessment Monitoring System, or PRAMS. They've implemented an opioid supplement and callback survey, which uses the existing PRAMS infrastructure to identify factors associated with opioid use and misuse during and after pregnancy. Data from these surveys will help inform programs and policies to reduce the risk of opioid exposure during pregnancy and ensure that women and infants receive access to recommended clinical care. 32 states added the opioid supplement to their PRAMS survey, as you can see on the map, and 2 states added these questions to their existing maternal and child health surveillance systems. 7 states will conduct a callback survey at 9 months postpartum of previously responding mothers to the supplement. Finally, I wanted to talk about our Rapid Maternal Overdose Review, or ARMOR, which supports maternal mortality review committees, or MMRCs, in 6 states to review all pregnancy-associated overdose deaths in the state. Through ARMOR, CDC is developing processes and tools that MMRCs can use to improve data quality to better capture, analyze, and prevent maternal overdose deaths. Data from this effort will be used to develop strategies for preventing overdose deaths in the future. Thank you so much for your time today.
Great. Thank you very much, Sherilyn. Now for some quick ASTHO updates. Thank you to all teams who have sent in their action plans. As a reminder for those still finalizing your plan, please reach out to ASTHO with any questions. We will be reviewing each action plan over the next couple of weeks, and we'll follow up with any questions or comments. Additionally, ASTHO staff will be reaching out to the points of contact to discuss establishing a regular check-in strategy with each state team. These check-ins will include updates on action plans and discussions on how ASTHO and our partners can continue to support your work. We're also excited to share a new activity launching this winter. ASTHO will be hosting state sharing technical assistance calls. These 30 to 60-minute calls will be an opportunity for OMNI team members to talk with each other and share information and resources around a focused specific topic. States will have the opportunity to present on their work, and after which ASTHO will facilitate questions and conversations among attendees. The first call will be in early December and will focus on expansion of Medicaid coverage for postpartum women beyond the 60 days. We're looking forward to an exciting and productive year ahead with all of you. As always, please don't hesitate to reach out to ASTHO staff with technical assistance requests to support your action plans. I'll now turn it over to my colleague Vic, who will close out our webinar.
Great. Thank you so much, everyone, for attending today's ASTHOConnect. Please take a moment to complete our evaluation module via the link in the chat box. Your evaluation of this Connect is very important to us as we're always striving for continuous improvement. If you are unable to complete the module at this time, you will receive the evaluation link via email within the next hour. Thank you so much and have a wonderful day.